Good morning, everyone. In today's discussion, I'll be elaborating a very important aspect of interventional pulmonology, which is respecting and understanding the limits of intervention. With greater reach in technology, it is vital that we understand when to step back, and this is all the talk is about. The talk is more philosophical than scientific, and I think the reason for this was that everything has been covered, and I think my friend Ravi thought how to fit this old friend of his into a talk. So he thought, okay, let me give him some philosophical talk. And secondly, you know the title of the next session, all that is left. So actually he had planned the title of this session as all who are left. So I think I was one of them. So please bear with me to be more philosophical that way. With age, possibly I have mellowed down, and so I think it can be an exhilarating experience for the beginners, for the novices. And why is it? Is because of this. So this is my first voice stand which I placed in 2010. I was joyed, it was like I was on the top of the world. I know everything. Now I'm the king of the world, right? The Titanic scene and so on and so forth. But what about this? The next voice stand which we placed. And this can be a stressful experience, especially for the beginners. And figure this out. If there is a complication, patient has hypoxemia and so on, it's a very challenging situation. So we really need to know when to stop, how to define our boundaries, and this is all the presentation is about. The point has been made very often, and I would still say it is a responsibility of the IP physician to know when to stop and know when to do. So how do we do that? That comes with clinical wisdom. By clinical wisdom, I mean attending meetings like these, talking with your colleagues and so on, which tempers your technical possibility. So if I was like that possibly a decade ago, but now I've completely changed. Our center is a moderate volume, I wouldn't call a high volume center. We do about 2,000 bronchoscopies a year, about 50 rigid bronchoscopies. It is dwindling now, and so on. And we have seen complication with practically everything. Deaths in a simple diagnostic flexible bronchoscopy. You saw my colleague yesterday showing me a case that we have the unique distinction of having a pneumothorax with suction. Pneumothorax after doing a bronchoalveolar lavage, and so on. We have had deaths with a simple convex probe EBUS procedure. So what we have realized is that interventional pulmonology should come with intervention humility. This is what we have realized over time. It should come with the realization that not every patient is a candidate for IP. There should be a careful multidisciplinary assessment to understand what are the risks involved, where will this procedure lead me, and so on. Most important, one should understand that technical feasibility is not always the end game. Whether it is clinically relevant or not. For instance, there's a patient of CA esophagus, there's a cranial involvement, but the patient is too sick. The Weisstein may be placed well, but the patient may go into the ICU, have post-operative ventilator-associated pneumonia, may not make it. So what is the point in having a well-placed Weisstein if the patient cannot make it? So you have to balance benefit with risk. So this is what all this talk is about. And the responsibility rests with academic centers like ours, because we are also training students. So if we do something which is rash, which is wrong, it is going to get multiplied several fold down the line. So this is very important for us. So it is the responsibility of academic centers to regularly revisit, update and standardize their protocols, not only for indications, but for the contraindications, the complications and how to deal with them. For example, I'll quote an incident. For instance, we were placing a lot of silicone vitamins a decade ago. So we used to place this high subglottic silicone stents, and then we used to suture them. And on follow-up, we realized that they were not holding up. Most of the sutures were breaking, the stents were having, the patients were having more complications. So we were placing the stents, despite suturing the stents were slipping down. There were some skin infections and so on and so forth, and we practically abandoned it. That was because we could maintain a complication on it. So that is what helped us. And then we moved from a high silicon stent to a Montgomery tube. So this is how we modified our procedure. And let's see some specifics. Karan has already covered most of it. He has shown some of my videos also. There is some overlap. So please don't mind, this is a very close-knit group, so this is usual that we show the same videos again and again. So airway stenting is supposed to be the maximum thing which you can do in IP. And it is mostly life-saving, but it can be life-altering also. For instance, if you place a stent which is not required, remember that it's a foreign body inside the airway. It can cause granulation tissue formation, it can migrate, it can fracture, like just Vikas has pointed out. You can have mucus plugging, and there can be significant infection. So we had a stereotrophmonas multifila infection in a patient with stent. It refused to go away till we remove the stent. So those will be the problems. And in benign stenosis, please, if you have placed a stent for some other reason, try to remove it as quickly as possible. It's going to be a problem later on otherwise. So what is our approach? We stent only following a multidisciplinary consensus. So for instance, it might sound very scary, multidisciplinary and so on. It's just two of your colleagues talking. Should we stent this patient? No, I don't think so. This patient will not make it. I think this patient is too sick. And that is what all this multidisciplinary. Don't do it alone. At least talk to your senior colleague or your junior colleague whether an indication is there for placing the stent. And we have certain do not stent scenarios. For instance, our first option in a benign brachial stenosis is referring the patient for a surgery. Only if the patient refuses to go for a surgery, then we move to the next IP option. Let's say you have a bilateral distal bronchial obstruction. You don't want to stent those people. It's not going to be useful for the patient. For instance, you want to place a stent, but the distal thing is blocked. There's already bronchiectasis there. What is the point in doing a procedure? And when the patient has a very poor general condition. So somebody may argue that this is where the IV should be doing, but this is where you have to strike a balance, because it can mean life or death. For instance, you can cut short the life of 4 weeks into just one day if you inadvertently intervene in a patient. So this adage summarizes our philosophy that the best stent is the one which has not yet been placed. So this is what our thing is: don't place stents unless you really have to. Then coming to some points about medical thoracoscopy, it's a very powerful tool, and fortunately we have not seen many complications with medical thoracoscopy, and the reason is because we use it appropriately. So in this gathering, appropriate may be very different for different people. So our appropriate use is using medical thoracoscopy only for diagnosis of unexplained exudative pleural effusions and for pleural disease. And when you overstress this indication, for instance, where my friend Arjun, multi-port procedures for empyema, lung biopsy and other things, so you're going to land yourself into a problem. I am not telling that you should not be doing these procedures, but if you are doing this, be ready for complications, and that should factor into your informed consent. I hope it does. And you give them the alternate option also. Rajni, please check their informed consent form also. And in Tamil also. And sometimes in Malayalam. So I think these are very important points. So if you overstretch the indication, then you're likely to die. So fortunately, we have not seen the bleed, which Dr. Pingley showed yesterday. I was really scared, that had this bleed happened. Many of us, because you're training the residents, if you have a bleed, it's very demoralizing for the training. So the only complication, fortunately, we have seen is re-expansion pulmonary edema, and that too now we have a protocol, so nobody has done that also now recently. Like somebody said yesterday that you take biopsies if you're doing rigid thoracoscopy over the rib, you feel the rib and take biopsies, and I think That is the most important reason why we have not had many complications. The other reason is maybe we have not done enough procedures and we are waiting for the complication to occur. That point is also there. So what is our approach in performing thoracoscopies? We do only pleural biopsies and pleurodesis, and that is also after algorithmic pre-procedure trial. So if your diagnosis can be easily achieved with pleural fluid investigation, for instance, as a young patient, fever, ED is 100, I don't think that patient requires a thoracoscopy. So you have to keep all those points in mind. And we are very, very conservative. We generally avoid patients with extensive pleural lesions, post-pleural disease, severe comorbidities, etc. And maybe that is the reason why our complication rate is low. Pulmonary nodules are actually more of a CT-guided biopsy plan. I refer most of our patients for CT-guided biopsies and image-guided biopsies, and that is the probable reason we are not seeing any complication. Our major complication with the pulmonary nodules is not achieving a diagnosis. So almost 30% of the patients do not get a diagnosis, and I think that is the most important point I tell my patient before venturing into this. Yeah, we have seen a few pneumothoraces while doing cryobiopsies for a solitary pulmonary, a peripheral pulmonary nodule. But other than that, initially we used to have sedation related complications because of the long procedure times. So we were not using fluoroscopy initially, so the procedure used to run into 30 minutes, 35 minutes. All that has decreased once we had a fluoroscopy with us. So what is our approach to pulmonary nodules? We use watchful waiting as a very powerful tool. I think this is a very important thing. So continue same treatment. Review after 3 weeks. I think this is a very important tool which we generally disregard. For instance, there's a single nodule, non-smoker, low risk. The patient can wait for some time, repeat a CT after 3 months. I don't think it will double or triple in that time. So if it does, it's very good. Then it's definitely not a malignancy. So I think you can wait in an asymptomatic patient. The unfortunate trend is a lot of CTs are being done, especially after the COVID infection, and a lot of nodules are getting biopsied with no clear diagnosis, and the patient is just scared. And there are two ways of explaining to the patient. You got a nodule. I think it can be malignant also, but it can be benign also, and we can repeat a CT after 3 months. You got a nodule. It's likely to be malignant, maybe benign. I think we should do a biopsy. If you explain consent, if you explain the procedure in two ways, the patient will opt always for the intervention because you're scaring the patient. So our selection is kind of multidisciplinary in the sense that we have a very close OPD. So they said, should we do? I think let's wait for some time. It's a single nodule, or there are multiple nodules. It looks like infection. Maybe the patient had a viral bronchiolitis, will go away. Let's repeat a CT after 4 weeks. And this is how we do. We don't search for peripheral complication more than 20 minutes, and this has led to our reduction of anesthesia-related complications. So if it's there in 20 minutes, it's there. If it's not there, then it goes to the image-guided biopsy protocol. And we have really integrated image-guided biopsy. In fact, our PET-guided biopsy rates are phenomenally high. I was just telling some of my colleagues that 90% plus in failed bronchoscopies and failed CT-guided biopsies also. So we really have integrated PET-guided biopsies into our nodule protocol. Then what is the other responsibility of academic centers, also as these called high volume centers? It is team training, which has already been pointed out. For instance, once we started training with the EBUS simulator and the mannequin for rigid bronchoscopies, our complication rate, injury to the mucosa, etc., really come down. So I see myself doing the first rigid bronchoscopy, and I see my student now doing the first rigid bronchoscopy. I'm scared. I say, how did I do that? I must have caused so much problem for the patient, and I see how confidently the student is doing because he has been trained on a mannequin. So I think that makes a lot of things easy for the training. I just show a few cases. Karan has already stolen most of the videos. So this patient was referred to us for failed tracheal stenosis dilatation. So there were two two passages as you saw in the video. So just see one passage. In one passage you have the normal airway, and look at the other passage. You can see the lung there. So this is how you learn over time. So in such things, it's better not to say, okay, that's a minor tear, I'll just use my rigid bronchoscope and go. Take time, see where the actual airway is, and then carry on with the procedure. And this, here we place the stent, and the tear healed by itself over the next 4 weeks. And this is a case which Karan was referring to. So we had this 44-year-old lady, very gentle family. The lady came with complaints of dry cough, and she was otherwise normal. There was some decreased breath sounds, and this was a CT. And you can see the fat density here, and the same fat density here. So we were sure that this is an endobronchial lipoma, and this was a time when we had just started doing procedures. I had gone to Dr. Rajiv Goyal's center, and he had done a carcinoid on that day. So if you remember, there was a carcinoid. So he just saw the carcinoid, lassoed the tumor, and then cautery, removed it, and he said, there's no problem, we'll do the same thing. Yeah, we'll do the same thing. So this looked like a very straightforward tumor, no problem. And we went ahead, we thought, okay, the tumor is there. We'll snare the tumor, and then we'll just remove the tumor using a forceps. And there should be no problem. Dr. Rajiv Goyal removed the carcinoid. There was bleeding, still nothing happened to the patient. And what would happen to this patient? So we went ahead, and it was a painless kind of procedure. So we could lasso the tumor in the first or the second attempt, and we applied cautery, and the technician said, sir, cut here. The tumor has been cut, so fine. And suddenly the patient coughed, and we thought it's all right. Then the patient was vigorously coughing, and we were doing suction and waiting, and so on and so forth. And suddenly, to our utter surprise, we found that the tumor is not there where it was previously present. It had flopped onto the other side. It had taken its own course. It said, you're not taking me out, so I'll try to move outside the airway. So this happened, and we thought, okay, no problem, we'll remove it. But this happened. There was sudden onset hypoxemia because the right main bronchus was blocked by the tumor. There was compensatory hypoperfusion, hypoventilation, and so on. And the tumor migrated to the other side. The ventilation was completely blocked, but the perfusion was still maintained. So it caused acute shunt physiology, and severe hypoxemia ensued. So the patient was intubated and shifted to ICU. I think this would have been the first case report of one procedure killing 2 patients. And how is that? Because the husband of this patient had a bypass 10 days ago, and he started having chest pain. He said, God, case report, 1 procedure, 2 deaths, and everybody was in a fix. So anyway, we went in with the patient. We did a flexible bronchoscopy. Once again, we pushed the tumor from the proximal left main bronchus to the distal left main bronchus. Saturation did improve to a bit, and then we did a bronchoscopy, and the tumor was removed. And fortunately, 2 deaths were avoided because of 1 procedure. And this is the follow-up bronchoscopy. And there's another important thing associated with this bronchoscopy. So this patient came for the bronchoscopy, and you will see that there's some residual tumor. Okay, see that there's some residual tumor. So we told the patient, if you don't mind, can we just do some cautery or something? Doctor, please leave me alone. And what she was doing, she was sitting outside the bronchoscopy room, And all the patients are saying, अपने लोगों से नमस्ते करते हुए जाओ. Greet your dear loved ones. You might not come out. And suddenly, we have a very heavy bronchoscopy list. Suddenly, there's no patient. Some patients have nicely, slipped away. So anyway, then what happened was the tumor regrew, and after 5 years, we again did the procedure, and this time we could remove the tumor entirely. So this is all I had to say. It was more of a philosophical talk in getting yourself into the groove that whether you're a very high volume center or wherever you are, complications will occur, and you need to exercise that restraint. You have to curb that interventionist instinct. And like Dr. Atul Mehta said several times, the mastery in interventional pulmonology is not only performing the procedures but choosing when not to. So I think that is the important take-home message for them. Thank you, ladies and gentlemen.